Good evening, everybody. If we could get started, that would be good. For those of you who don't know me, my name is Andy Shadrack. I'm Director for Area D. I'm going to chair the meeting tonight. Joining me at the head table are Tom Humphries, Mary Ballard, Maggie Winter, Maggie Crow, and Neil Lane. We, for the last 12 months, have been your negotiation committee with IHA. We're going to report back to you tonight on what we've tried to do, what we've most recently been told, and then we're looking for some direction from you as to how you want us to move forward.
Speak up a bit, please, Andy.
Okay? How's that? Good. Keep reminding me. It's been a long week. So we're going to start with Maggie Winter, who's been one of our chief negotiators, giving you a report on what we've been trying to do. So I'm going to hand it over to Maggie.
Hello, everyone. First of all, thank you for all coming out tonight and for your interest and support as we continue to work to ensure the healthcare safety of the citizens of Kaslo and Area D. A year ago this month, Interior Health announced that due to physician pressures and nursing shortages, the emergency room hours of operation at the Victorian Community Health Center would be drastically reduced. In response to the Interior Health announcement and following a community meeting, the Kaslo and Area Healthcare Working Group was formed by Kaslo Mayor Greg Lay and Area D Director Andy Shadrack. I have been privileged to serve on this committee since its inception and have over time become the primary spokesperson. This committee made it clear to Interior Health from the onset that we were interested in engaging in a constructive dialogue regarding the issues that brought about the proposed reduction in ER hours, and that the community was committed to doing everything possible to preserve 24/7 services at our health center. Interior Health agreed to enter into that dialogue and hence began what has to date been a year-long process, at times encouraging and at times extremely frustrating. We learned much about the challenges Interior Health faces in providing service to rural and remote communities, but we also concluded that they had not devoted anywhere near the time, energy, and resources needed to address those challenges, instead opting to take the easy way out and simply reduce services. We can understand how frustrated the community must be at this point to learn that it does not appear that IH has budged from their original intention of reducing our emergency room hours. It would be easy to believe that our year of hard work by this committee has accomplished nothing. But before we all draw that conclusion, I would like to take a few minutes to review what has occurred over the past year, what we have accomplished in the current status as we understand it as of 6 p.m. today. Here's what has occurred in the last year and what we have learned. The early months were spent in gathering information that would help us better understand the issues, such as ER volumes, acuity levels, and ambulance transfer statistics. We learned that many ER visits were not true emergencies, but more appropriately reflected the lack of the availability of non-traditional primary care hours. We also learned that Interior Health manages to meet the ministry mandate of that 95% of the population must be within 1 hour of an emergency room by including a large population area extending down to and including Grand Forks, in other words, the entire Kootenai boundary area. This effectively dilutes the impact of the North Kootenai Lake residents on our overall population. During this time period, we engaged in a series of teleconferences that included IH staff from medical affairs as well as community integration. Those teleconferences eventually led to the development of a joint steering committee that Maggie Crow and I sat on with IH staff from community and residential services, community integration, and communication. It was this committee that designed and implemented the community consultation process that so many of you actively participated in. The culmination of that consultation process was the Future State Workshop held in April, where community members and administrative staff from Interior Health, as well as the BC Ambulance Service, came together to discuss healthcare service delivery options for the Victorian Community Health Center. The breakout sessions concentrated on 6 main topics: 24/7 ER services, quality and continuity of primary care, health center and staffing, community engagement and Interior Health, transportation and ambulance services, and technology. Out of that workshop came many creative and forward-thinking ideas for redesigning the way healthcare services are delivered here in Kaslo, and many community members signed up with the Interior Health staff to work on these ideas. What became abundantly clear from both the focus group sessions and the workshop was that the clear priority for moving forward was to develop a model of care that ensured the safety of the residents of Kaslo and the surrounding area, and that remains our mandate moving forward. Unfortunately, after the workshop, communications broke down in many respects, and the stated intentions of Interior Health to include our committee in the process moving forward came to a grinding halt. We repeatedly asked for a copy of the Ross report, and we were repeatedly told it was not ready. And we continued throughout the summer to receive conflicting reports of when it would be available. This was extremely frustrating and discouraging, as so much forward momentum appeared to be riding on delivery of the Ross report. That delay just increased the level of anxiety and uncertainty in the community. We repeatedly asked for updates on the development of the proposed new model of care from our liaison in Andrew Nooner's Community Integration Department, and we were stonewalled to the point of not having repeated emails returned. In late July, we had a meeting with Andrew Nooner and Dr. Michael Purdon here in Kaslo. At that time, they again proposed we agree to a reduction in ER hours, and we refused, based on the knowledge that there were no backup plans in place to ensure the safety of our residents. We also remained convinced that the claim made that physicians could not be recruited for Kaslo under the current system was inaccurate. So that brings us to tonight and the current situation. As everyone here is aware, we currently have one contracted part-time physician, and we have experienced excessively long waits for primary care appointments, and we've experienced significant periods of disruption in ER services over the summer months. It would be easy to be very discouraged and angry and feel that we have accomplished nothing and that we're right back where we started last September. But that's not entirely true. Here's what we have accomplished. We have established some very positive working relationships with a number of senior executives in Interior Health who we believe do want to see a positive outcome for Kaslo, and a couple of those have contacted me today. We now actively participate in interviews with prospective physicians. We do have the results from the community focus groups and the April workshop that clearly indicate the wants and needs of the community and clearly outline a number of directions that can be pursued going forward and those willing to work on them. We do have the Ross report. Hopefully many of you have been able to access that online. There's even a hard copy available at the library, and there are hard copies, thank you to Andy LeCouf, available up here. A few in number, so if you decide to take one, please consider sharing it with a neighbor. As I said, we do have that Ross report that supports our belief that emergency services are necessary for rural areas such as Kaslo, and that positive change may require a willingness on the part of all parties to look at alternatives to the traditional physician on-call system we are currently having problems sustaining, and provides very clear avenues that can be pursued. We have provided the impetus for groups within and outside IH who have traditionally not communicated extensively with each other to do so, hence identifying the weaknesses and strengths that we hope will now be addressed. The manner in which the announcement came about from Interior Health that Interior Health still planned to pursue a reduction in our ER hours was very unfortunate and led to considerable confusion in the community and within our group. Andy will discuss that in more detail in a minute. However, in the last few days, this committee has worked very hard to not only clarify the situation, but to pursue a more detailed description of what to expect in the coming months. Here is what we know as of 6 p.m. today. Interior Health has acknowledged and apologized for the delay in getting the Ross report to us in a timely manner that would have allowed us to review and discuss it prior to the UBCM conference and the meeting between Village Council members Andy Shadrack and Dr. Helfman. Again, Andy will describe that meeting in more detail in a moment. Unfortunately, apologies from Interior Health with respect to their lack of communication skills are wearing a bit thin. Interior Health has clearly indicated that they intend to continue to work with the community in the coming months as the transition to reduced hours occurs. We do not have a firm date for that transition. We don't even have an idea at the moment of how long it will be before that might occur. But we have made it extremely clear to Interior Health that we expect adequate support systems to be in place prior to any reduction in emergency room hours, and that we see any reduction as potentially temporary as we explore options for how we might reinstate 24/7 service once primary care is stabilized and how we can utilize the recommendations in the Ross report in designing that service. There are no barriers to this community engaging in active physician recruitment. However, there do appear to be barriers in terms of the wording of the contract physicians are asked to sign, and Tom Humphreys is going to explore that issue a bit more in a few minutes. Interior Health will be putting the resources of the practice support program into helping refine the operations of the primary care clinic to better serve patients. We've been told the clerical staff of the clinic will be trained to transition into the role of medical office assistants. This is a barrier prospective physicians have mentioned in affecting their decision to relocate to Kaslo. Once the physician component is stabilized, additional training will be offered to registered nurses and physicians to build on the skills necessary to handle high acuity patients needing resuscitation, intubation, and trauma care. Discussion around the role of a nurse practitioner in our clinic will occur, with consideration given to putting in an application for a nurse practitioner position in Kaslo. Discussion will occur around how to prioritize the community input received in the spring and where improvements based on that input can occur. And processes will be put into place to reduce the current wait time for appointments. The Medical Affairs and Clinical Networks Director has agreed to come to Kaslo to discuss transportation issues and explain the role of the helicopter, fixed wing, and ground transportation options and how BCAS and the HEART team can assist in providing timely access to high-level care for patients who are critically ill or injured. Efforts are now underway to have a chief pilot visit, and this involves having the chief helicopter pilot stationed at Kamloops coming to Kaslo and the Lardo Valley to work with first responders on how to identify and prepare a temporary landing site for emergent transfers. Our intent, as I said, this is what we have as of today at 6 p.m. Our intent is to develop and devise and communicate a means of making sure that we keep you updated as this sort of flowing situation continues to develop. So I'm now going to turn the meeting over to Andy for an update on what happened at the UBCM conference.
So, the Ross report was basically released, I think, on Wednesday or Thursday of the week before UBCM. It was released only to the elected officials, attempting to split the committee in two, so the non-elected officials couldn't see the report. We then went into a meeting with Dr. Halpenny on the Monday, the 16th, in which he announced the ER was being closed, period. That we would have a primary health center, and that was it. He even went into details of what services we would no longer have in Kaslo. The next day, we went and met with the Minister of Health. And in that meeting, it was explained to the Minister of Health that we'd had the Ross report dropped on us. We hadn't had a chance to talk as a committee or with the community about the Ross report. And once again, the IHA was unilaterally making decisions without any ability for us to respond. And I got a promise out of the Minister that day that we would have the time in this community to be able to respond to the Ross report. Since that time, we've been going back and forth. I talked to Dr. Purdon on Saturday of last week after UBCM was over, and Maggie and me have been talking, and you've heard from her. But to give you an idea of how unfortunate the situation is, though, I have to choose my words carefully, I guess. I talked to Chris Mason today. He's the superintendent for BCAS. The last time the IHA talked to BCAS about transportation issues was in April. So from my perspective, what's going on is they're trying to drop a plan on us without actually having anything in place. So I'll leave it at that. I'll pass it back to Tom. I've got some ideas, but we really do need you to tell us what you want us to continue to do.
Thanks, Andy. Well, you can't recruit physicians without a good and predictable contract. And we'd all been hearing about this contract that the physicians were being asked to sign that had, as one of its terms, a very uncertain requirement as to the hours the physicians would have to put in. So in the last few days, we've heard about this for a long time, and we've all been busy and working on the whole project, but other things too, obviously. So in the last few days, I took it on myself to actually examine this problem in detail. And I spoke with physicians, and I spoke with the BCMA lawyer, the BC Medical Association lawyer, and I spoke with the negotiator at the BCMA just to see what exactly was supposed to happen in terms of the contract negotiations. The first thing I did, and you can all look at this, it's interesting, we all thought that this contract was top secret. No one could see it. Well, the template contract, the standard contract, is not top secret at all. It's on the internet. If you want to write this down, if you're interested, if you Google 2012 Physician Master Agreement, Ministry of Health in BC, this is about a 200-page document, but as part of that document, only a lawyer would want to find that out. But part of that document contains the actual contract that the type of facility that Kaslo has is supposed to be using, or the physicians that work for the facility. We don't have fee-for-service here. So this contract is it's part of the master agreement, physician master agreement, but it's governed by a sub-agreement within the master agreement, which is called the Alternative Payments Agreement. And the Alternative Payments Agreement is meant to govern the payments for doctors who are not fee-for-service in little places like this. So I was researching, and we'd heard this thing about in the contract that you had this range of hours that physicians in Kaslo and other places would be expected to work if they signed the contract. And when we heard what was apparently required, we all said, well, why would anyone sign a contract like that? It's a huge range. You could be responsible for up to 2,400 hours a year under this contract. So, and a minimum of, I think, is 1,680. So, you know, as a lawyer, I thought, well, that flies in the face of all contract law that I know. A contract has to be predictable. Why would anyone sign it? It just doesn't make sense. So I thought someone was wrong. I thought, this can't be right. So anyway, I researched it, and within this document that I'm talking about, I found the template agreement. There are two template agreements that could theoretically apply to physicians working in places like this, but one of them doesn't apply. One of them is called a sessional or a sessions contract, and just without going into it, it doesn't apply. But one of the things in that standard contract is that there is a provision for a range of hours if you're working as a sessional physician. But for the standard service contract, which is the one that we are dealing with, it's required, the agreement actually requires that the physician and the agency, i.e. IHA, come to an agreement about the number of hours the physician is going to work during the year. And that number of hours is between 1,680 and 2,400. So there's a whole range of hours that you can work with, but you're supposed to, the two parties who have equal bargaining power are supposed to come up with a number. But this isn't how it works. So again, I thought, well, I've got to be missing something. So that's when I phoned the BCMA lawyer, and I said, look, this is what I think, this is where I got to in the legislation and in the master agreement and in the template agreement. Am I right or wrong? And she said, no, you're right. They're supposed to, the employer is supposed to come to an agreement with the physician for a certain number of hours a year. I said, well, apparently that's not being done. Why not? And she said, well, the government, just in general using that term, takes the position that you can insert that range, 1,680 hours to 2,400 hours, and that's just fine. That's the way it's supposed to be. If you look at this thing, I'll just give you the page number. Because all of this document itself, that when you Google this document, you'll see that the template service contract and the other documents that go with it all have page numbers at the top. So look at page 100, article 11.3. And this is where it says, the parties to intended service contracts, and that's what we're talking about, must attempt to reach agreement on the number of hours per year between 1,680 and 2,400. that will constitute a full-time equivalent under the service contracts, and the following shall apply. And then it goes into a thing where the parties can get a troubleshooter to fix if they can't agree, then they get a troubleshooter to look at what the number of hours per year should be. My point in all this, though, is that the contract somewhere back in the dark ages seems to have become a hybrid of this sessional contract that I was talking about and the service contract that they're supposed to be using. And someone way back when started inserting this range of hours. So of course, physicians don't want to sign this. Why would they? So I phoned, after the BCMA lawyer, I phoned the BCMA negotiator, one of them. And this is a person who helps doctors negotiate contracts with health authorities. So I said again, this seems very strange that this is happening. Why would anyone ever sign a contract like this? And she said, most of the negotiations we do are involving this particular problem. We know that the agencies, the health authorities, IHA, whoever, should not be trying to insert this range of hours because it makes it difficult for doctors. She said the 2,400-hour thing was dreamed up way back when someone was looking at the number of hours that perhaps a plastic surgeon might have to put into a year's work because they get called on short notice and so on. The 1680, I think works out to 7.5 hours, more or less 46 weeks a year or something like that. So that's sort of a minimum. She said the BCMA's position, as the negotiator's position and the BCMA's position, acting on behalf of doctors, is that these contracts should not contain a range of hours. They would advise doctors not to sign a contract that contains this huge range of hours, which we understand these contracts that the doctors here are being offered do contain that huge range of hours. I am aware of one situation where a doctor had that range whittled down, and the negotiator said that they do a lot of that. If they can't convince the agency to give a discrete, that is, a single number of hours, they take the position that, okay, we'll try the least of all evils, and we'll work out a narrow range. So they do negotiate contracts with a narrow range, but as we understand it, as I understand it, so far IHA doesn't present that kind of contract. So how do you recruit physicians when you've got that kind of a contract out there? I don't think you can do it. So that's the problem with the contract.
Now, do you want to go through the Ross report?
Has everyone received a copy of the Ross recommendations and Interior Health's response? They were available at the door. Just out of curiosity, prior to coming to this meeting, how many people had been successful in obtaining a copy of this report and had looked at it? Yay, thank you, that's good. So we're just going to really quickly go through the contract because the idea of going through, contract on my brain after listening to Tom. We're going to go through these recommendations just really quickly because what we're really looking for as you think about how we go forward is we're looking for people to stand up and tell us and give us ideas for how they might like to address some of these recommendations or if some people might be interested in becoming part of a group that looks at addressing some of these recommendations, perhaps doing some research. So anyway, the first recommendation, we categorized them, so they aren't going to go in the exact order that they appeared in the actual report. What we did, and actually Mary Ballin here is just our super researcher and organizer, and she managed to group these responses or these recommendations into three different groups. One was recruitment of physicians, the other were urgent care needs for the community, and the third one was management of the Victorian Community Health Center. So the first recommendation was that there should be consideration given to rerouting physician contracts to be less complicated while including performance criteria and performance deliverables. And then a focus should be made on maximizing the attractiveness of a rural practice while minimizing Ministry of Health and Interior Health Association programs administration. This will also leave time for involvement in healthcare center leadership and co-management. Let's just make a couple remarks about that. This This is a complaint we've heard over and over again from physicians who have worked in the health center, and it is that the administrative tasks associated with being a physician in the type of practice that they have in our health center is extremely onerous, and that it takes away valuable time from their ability to deliver patient care. And also, one of the things we identified early on was there are some requirements within the family practice legislation that say that within a clinic situation or within any situation where physicians are working together, there needs to be a leadership component on the physician part. And we've never had that, and there's never been a requirement from Interior Health for there to be a lead physician in Kaslo. So this has been one of the things we're also pushing for, is that there is an identified co-manager of that clinic, and that person is a physician. So anyway, the Interior Health response was streamlining contracts and paperwork largely relates to locums, so they really did not get it. Temporary physicians, and we are open to exploring ideas to streamline this process. Well, so we're obviously talking about two different things here, because Dr. Ross was talking about full-time physicians or contracted part-time physicians, and they were talking about locums, so we've got a disconnect going on there. Number two, IH should facilitate processes that free physicians from the complex paperwork associated with ministry programs, and the goal should be to maximize their strengths and clinical knowledge and skills and minimize their relative weakness in following myriad program rules and processes. And Interior Health has stated that physician local support for rural communities is provided through the provincial rural GP local program that has been established and operated by the Joint Standing Committee on Rural Issues. And the GSC is comprised of representatives from rural physicians, health authorities, and the BC Medical Association and Ministry of Health. And they will bring the ideas being raised for local physician coverage forward for consideration by JCH. My response to that is, and our committee response is to say, you missed the boat here. You're not understanding what he has tried to tell you here, and it's really, from what we've talked about with physicians, it's saying that there's a lot of paperwork that could be done by somebody besides a physician at the local site level. I should consider negotiating with the funder, which would be the medical services plan, to enable physician self-locuming. As a patient-centered strategy, it would serve as an incentive for contracted physicians to spend more time in Kaslo. It will enhance the continuity of permanence of the physician workforce. It would also make ministry funding more effective when decreasing health center staff time, recruiting and supporting frequent local coverage. One of the most onerous administrative tasks that physicians working here, particularly if they're part-time, includes the requirement that they find their own locum coverage when they are going to either be on vacation or away from the clinic for some other reason. And they have not been allowed, it is not allowed for another physician who may be on a part-time contract to actually cover for that other physician. They're not allowed, in other words, to self-locum. So. Yeah, otherwise, we get lost. Anyway, sorry. Urgent care needs for the community is the second category. And he talked a lot, I won't go into this in detail, but he did talk a lot about requiring critical care maintenance and competency. And I did see, at least today in some of the responses that we received from Dr. Burden, that they are looking at that, and that there are a number of programs, and they are going to make an effort to bring some of that critical care competency maintenance to Kaslo. And the third recommendation said that several options can be considered to maximize physician resource effectiveness. He recommends adding a nurse practitioner to the primary health care clinic to reduce some of the physician time there. The role could be used as a physician extender. Depending on the individual, he or she may be able to participate in the on-call rotation. He suggests maintaining the physician on-call schedule, but book only an afternoon clinic after the physician has been on call the night before, or modify the need for on-site physician availability after hours by creating a nurse practitioner, nurse paramedic, late evening, night emergency care service. An oversight physician could be available at another Interior Health site or virtually anywhere. And this is currently being done in Nova Scotia with an RN paramedic and an RN. It is about to be implemented in PEI. The physician oversight role could be similar to or even added to the current IH transport advisor role. It would require specific protocols and training. Anyway, the response to this recommendation is that in BC, this is what they said, nurse practitioners receive education that prepares them to work in clinic settings rather than in specialty areas such as emergency departments. Nurse practitioners are also required to consult with or refer to physicians when a patient's diagnosis and care is beyond their scope of practice. That must mean that a physician must be available to respond to a nurse practitioner's request for assistance with a complex patient issue. Okay, and that's exactly what Dr. Ross said, was that that physician could be available, but didn't necessarily need to be on site. And we do know that there are examples of nurse practitioners who are covering emergency services in other areas. So that doesn't hold in BC, and that does not hold water as well. It says that Interior Health has nurse practitioners working in rural areas in collaboration with physicians, and this is a model that can be effective in meeting the needs, again, but they're talking about simply primary care. Their final statement with respect to this is the remote physician emergency model Dr. Ross references in Nova Scotia may not, quote unquote, may not be applicable in BC. Nova Scotia has a different legislative framework and different community needs. Okay, so the third recommendation is to follow up on arranging HEART site-based refresher training for all appropriate staff, and it appears that they are going to move forward with that. Exploring opportunities offered by the Vancouver Foundation for paramedic development as an innovative community project. And again, this is something that perhaps there would be a group in the community that would like to explore this option. Skills enhancement and maintenance is he suggested developing a relationship with the emergency departments in Nelson Trail that would enable regular shifts to be covered by nurses and physicians whose primary site is in Kaslo or other small rural sites, ideally in a double coverage arrangement to maintain emergency assessment and treatment and knowledge and skills. And I think that makes a lot of sense because we don't see a lot of trauma in Nelson, but we do see it. Nurses and physicians need to be prepared to deal with it. Number 6, IHA and BCA's personnel have developed an excellent collaborative relationship. Continuing to identify and address the system demands and supply challenges are key to having a seamless emergency response and transfer system. And so as Andy already told you, so far at least, there has not been a lot of communication between Interior Health and the BC Ambulance Service. That obviously needs to improve in the future. And in the rural setting, it's vital to continue paramedic staff development and sharing of a multitask worker staff, such as an advanced care attendant in the ambulance as well as in the health center. Rural centers need to explore more creative staffing models to leverage the skills and knowledge of the healthcare providers in the area. And IH and the BC Ambulance Service should continue to collaborate on the development of easy-to-follow emergency care protocols and algorithms for time-sensitive but uncommon health problems. And basically the response was, we will continue to work with BCAS, both locally and at the provincial level, to ensure residents have access to timely emergency transport, skilled paramedics, and Interior Health's high-acuity response team. And they go back to focus on developing a strong, robust primary care model that provides area residents with consistent care that they need on a regular basis. Once that is in place, they are willing to explore options such as introducing paramedic skills into the health center. An initiative like this has the potential to attract and retain paramedics in rural communities and complement the multidisciplinary healthcare team. So we just go back again, we've come back to IH and said, you know, this all sounds great, except that some of these things need to be in place before you reduce the hours, not after. The time isn't after the hours are reduced to explore these options. In terms of management of the Victorian Community Health Center, he talks about recruitment, and he says he'd like to consider collaborative recruitment of clinical staff and local management with active participation from community members. For example, community members, representatives, patient-centered, could join staff on interview and selection committees. And he said, no, this is we are already doing this with physician applicants, but he is suggesting that it could be expanded to other people working within the health center. IH says that while this is an interesting concept, privacy legislation and collective agreements would likely make it unworkable to involve community members in staff interviews, but we already know that this is occurring in other centers, so I'm not sure that that's I'm not sure they know what's going on within their own house. Consideration could be given to a staffing model that includes more full-time and part-time positions than casual employees. The increased upfront costs would need to be weighed against the potential gains in staffing stability, potential decreased overtime, and unplanned service interruptions. A commitment by Interior Health should yield a return commitment for a more stable local workforce. Interior Health, and we've said this all along, that a lot of the issues and what we've heard from talking to staff at the health center is that many of the issues with closure of the ER that they so happily blamed on nurses in last September are really related to the way the hiring practices and the fact that there are very few full-time nursing positions compared to part-time positions. One of the things that got me up on my feet at the last September's meeting, and I was sitting down there saying, I'm not getting up. But they made one remark that made me jump to my feet, literally, practically knocking my husband over. And that was when they said they couldn't find full-time positions for Kaslo, when I had just literally the day before listened to a good friend of mine's son-in-law complain about the fact that he was being forced to move to Calgary in order to get a full-time position, and how badly he wanted to stay in this area and continue to serve the citizens of Kootenay Lake. Anyway, consideration should be given to a staffing model that takes into account the different responsibilities of the emergency and residential nursing care duties. And one of the things when they came up last September with the concept of this advanced care attendant is the question we had was, and as being a nurse, I can certainly attest to this, is that there's a very different skill set and a very different interest set in people who do residential care versus people who do emergency room care. It's two completely different ends of the spectrum, and I'm not sure that there's an understanding of that. Emphasis should be placed on strengthening health center leadership with a view to the development of co-management models shared between non-physician and physician leaders. And this is something we've hammered on this past year, is that we need a full-time manager at our healthcare center, one that pays attention to the entire healthcare center, one that is accessible and accountable to the community. We are looking for annual reports. We are looking for goals and objectives set for where our community health center should be moving, what we should be looking at accomplishing in the next year, and you know, what is the activity level of our health center, where are we going? So we're not getting any of that because we don't have full-time leadership at our health center. When they went to a centralized management structure within Interior Health, it means that the manager, the administrative manager, certainly for our site, might get over once a month if we're lucky. That is not effective from a management standpoint, and so those are one of the things that we've really hammered on to be addressed. And interestingly enough, this was not something that was addressed by Interior Health. This recommendation was not addressed. Having regular healthcare provider meetings where each discipline spends a few minutes educating others about their role in the community, changes in their profession, and other roles that they could provide. He really thought that there needed to be a lot more communication between various different disciplines that all operate out of our healthcare center, because many times they are addressing the needs of the same patients, and so there needs to be more of that type of a collaborative approach. And considering and creating an explicit, simple accountability framework for managing and reporting the multiple services, roles, and expectations of a rural sites such as Kaslo and others like it. And again, that's what we sort of went into, is we haven't up to this date felt like there's any accountability on the part of the healthcare center management to the community, and we're looking for that.
So there you have it. That's what we've been up to for the last year. We haven't got much in terms of results. I'd now like to give the mayor a chance to say something, and then we will ask you to come up and tell us what you think, or ask some more questions of us. If you could keep your comments down to about a minute, then we should be able to get this. What direction do you want us to now take?
Well, it's certainly been an adventure the last year and a disappointing conclusion with IHA. We went to them and said we want to work on solutions, and they came back to us with no solutions. So now we have to aggressively pursue what we think the solutions are. But they produced a document called Charting the Course, Interior Health Planning Principles and Consideration for Change. If you get a chance, you can read it. It's been referred to on websites, but I just want to read the one sentence that's the key to our success here. And that is, with this lens in mind, Charting the Course, Interior Health Planning Principles and Considerations for Change provides staff, physicians, decision makers, and community partners an overarching framework to use as a guide to make decisions on the planning and delivery of services. My belief is they're non-compliant with that statement. It's almost like this is a propaganda document to lure you into a false sense of security that will take care of you. So I really am happy of all the people who've turned out for this meeting so that we can help inform you. I would encourage you to learn as much as you can, because we want to take our healthcare system back. And it says here we're supposed to be able to. And I think that's the message that we want to pass on to the IHA.
So this is your health care services you pay for. This is your need. This is your health care services you pay for them. This is your community. So there's the mic. Who's going to be first up to start talking to us tonight?
I had to do a lot of deep breathing to get through that. That's really wild stuff. And I applaud you for your efforts in dealing with a stonewalling panel of people, bureaucrats. Maybe I'm just not close. Is that good? All right. Well, there's a lot of double talk going on there.
Did you follow?
All right, okay. What I want to know is, it seems to me that IHA is a very top-heavy business model that's controlling our funds. Can we fire them?
That crossed our mind. So I had my doubts about that kind of approach from the beginning, so I'm looking at that too. And I can't see, Ken, that there's any way you can do that. You know, let me say too that there are some people in the IHA that have been encouraging with us, and they're good to work with, and there are others who we haven't worked so well with. So I say that because we are stuck with working with the IHA. The legislation doesn't allow local boards like it used to. There's a Health Authorities Act, and then passed in 1996 or something. In 2001, there was a Health Authorities Regulation which was passed, which created the various health authorities, and subsumed within those various health authorities were all the local boards, and the Nelson and Area Health Council was subsumed within the IHA jurisdiction. So we don't have any choice anymore. So
I thought, I heard of some northern communities that we got rid of IHA.
no, I don't think that's true. I've heard that too, and I spoke with at least two or three people from Fort St. James, because I heard that that's maybe where that kind of thing had happened. And that's not really what happened. They still have to work with Northern Health, but they found inventive ways to fund their physicians by forming a society. That's a long story, but it's not doing what you want to do.
Well, good for you though.
So at the ministers' meeting, or the IHA meeting, Dr. Halping made a very clear, blunt statement that there would be no 24/7 ER in Kaslo. He did go on to say that he was indicating that there could be 24/7 health care in Kaslo. Now, I don't know exactly what the differences are, but I've got a feeling that, and he made some very valid points around some very critical trauma-type cases, that in a lot of situations, it would be not in the patient's interest to wait or stop in Kaslo, but then head on down to where they can actually be treated with some of the more serious cases. So I'm just wondering if, wouldn't it be lovely if there was just a little bit of crossing in terminology, that probably Kaslo has had 24/7 health care for ever since, and that's what we've had, and that maybe the classification of an emergency room is something that Kaslo won't have, because we don't have an ER anymore, or an OR anymore. So without the operating room, maybe it is better in a lot of cases where these guys head on and keep on going down the highway. Where all this hangs is around the definition of what 24/7 healthcare is. And I did ask Dr. Alkindi if that meant that my kid woke up with a fever in the middle of the night at 110 degrees, that I would have a place to take him to the hospital where somebody could do the assessment, and then is either go home, take an aspirin, or get your butt in the ambulance and you're off to Nelson Trail. Now, if that's the model, and one of the things I want to ask is that the committee give us a definition of what 24/7 healthcare is, because if you did commit to that. If that's the model, I think it'd be extremely important for the community to focus its efforts on transportation, ambulance, and even heart. And it would be a huge value. Having a heart team in Trail is just a little bit too far for us. Maybe we could really put some energy into getting a heart team in Nelson, which would be a lot closer to us. And again, maybe I'm dreaming, but I would like to be on the optimistic side and think that 24/7 healthcare is not very far from what we've got now. Maybe we should be fighting for something really hard on that front, rather than going after them on the ER front. Because I was sitting there, I watched him point at us, look us all three in the eyeballs and go, no 24/7 ER. But he did promise 24/7 healthcare.
Trying to define this has been like trying to put shape to Jello, to be honest. Every time we as a committee have tried to pin them down to what they mean when they say they want to change the current model, they've not come up with something to our satisfaction. Is that correct? So, we cannot define. Our bottom line has been everybody in this room's security and health. And they have not been able to define that. We've got to have IHA, the ambulance service, the nurses, BCMA in the same room. And when they roll out a model, we've got to be able to go around the room and ask each of those components, does this work or not? Because we're not going to agree to something that doesn't work for the people of these communities.
Jim, I loved your remark, about the heart team being down in Trail, so far away. I need to share an anecdote, which I'm sure that everyone in this room will get a chuckle out of. When Dr. Ross first came to BC, he came to Kelowna first, and he did a teleconference in Kelowna that I was able to teleconference into and listen to him present to all of the upper management staff in Kelowna. And at that point, he had just been looking at sort of the area that was covered by Interior Health. And one of his questions to the staff there was, and he can be so innocent when he wants to be. And so one of his questions was, he says, well, I'm looking at this map. He says, and I'm looking at where the heart team's located. And he says, I'm scratching my head, because I'm assuming that you got some kind of thing going on with the U.S. where, maybe there's some cross-border, transfer of care, because why would you have it down in Trail? So, what was most interesting was the level of silence that followed that remark. And then somebody piped up and said, I don't think we're going to discuss that right now.
Interior Health brought Dr. Ross to our community to work with us towards solutions. I am going through his report paragraph by paragraph, making notes for the upcoming sessions. I think Dr. Ross got it right. I think IHA have got it wrong.
Can you hear me? Hello? No? I'm not sure the mic works. Oh, you gotta eat it. Couple of questions and then a comment and maybe a ray of light for yourself. What do they just say is primary care? What do they describe that
Thanks, Sandy. Basically, what they're seeing as primary care is what you would traditionally think of as ongoing preventive and maintenance care. In other words, preventive services, maintenance services, and the actual definition of primary care in the Ross report, thank you, is the provision of integrated, accessible healthcare services by clinicians who are accountable for addressing a large majority of personal healthcare needs, developing a sustained partnership with patients, and practicing in the context of the family and the community. And this is from the Institute of Medicine Committee on the Future of Primary Care. And primary health care is defined as a set of universally accessible first-level services, and I think this more appropriately answers your question, that promote health, prevent disease, and provide diagnostic, curative, rehabilitative, supportive, and palliative services. And that's from the Canadian Health Services Research Foundation.
And they're indicating that that's one of the services we'll have here, is that correct?
That's how Dr. Ross
And how
defines
does the
primary care.
IHA, how does the IHA here?
I think that they would accept that. That's
Okay,
it.
and that's fairly good coverage, although it's primary care in a number of areas, and it failed because the unable to put the whole team together that under primary care, which is mental health and you name it, it's there. So I'm not so sure you're going to get the whole new deal. The other point I wanted to make, and that was to do with health boards. Somehow, some way, I moved this from Lumpy. I've been on the health board there for 5 years. We have a health board. We do all the things you're talking about. Yes, we have to work with IHA in a harmonious relationship. But we have a health board that makes decisions, that did bring in a new physician, that did set hours, did all that. So it's here in the province. I can give you contact with the lady.
Was that a fee-for-service situation?
We have our own manager that we hire, and it's up and running.
But I take it though that that board still has to work with the IHA because they provide the bundle of services, right? That's what I mean. We can't run the hospital because.
No, and you can't hire doctors either, but you can help hire doctors, and that's what they do. So I will give you the name of the lady if you're interested to know what their model is there afterwards. So I think you've done a great job, you guys. Hats off to you, and I know how frustrating it is. I did sit as a councillor rep in Alberta with the health authority there, and it still really consumes me when I looked at all the salaries online today and the number of people that are the higher echelon. We actually had a 4x4 block of people, all belonging to the health authorities in Edmonton. It was just disgusting. So I don't know, that's another fight for another time. They tell you today you're only going to get 9 to 5. I cannot see when they get emergency 9 to 5. It's about the kid who gets the irritant in the middle of the night, the guy who gets a bleeding ulcer in the middle of the night. What are they going to do with them? I'm just particular problem. And can we find that out? Thank you very much.
Last year,
Can you speak close to the mic, please?
Speak up. Last September, when IHA was here, they came here with all their glory, their pomp, and they sat at this table here with all their wonderful ideas and remarks of what we're going to do. And it seems to me the Kaslo population set them away because they were condescending in their approach towards us. And in that kind of patronizing way, I think they went away with their tail between their legs. And they probably have an attitude or feeling that, they didn't listen to us, so why should we listen to them? So is there a way that I feel we can maybe repair this relationship that seemed to have gone even a year ago? Because what they're saying today in their report is, we will, and as you may know, being a child, the parent says, we will see, and you know that this is never going to happen. So we've got to change these we wills into we do or will do. So is there a relationship with IHA that we broke because of the way they came to us last year, sat here with all their wonderful glory, and then we kind of pounced on them, and they didn't feel very good with it.
I'd like to respond to that. These are people who, they're employees of the government. We pay our taxes, we pay their salaries. They don't have a right to be dead. That's not their job description.
They don't have a right.
They have to take whatever we say as long as it's polite, and they have to respond by doing their job.
Yes.
That's the end of it. Pardon me?
Be professional.
Oh, exactly. Yeah. So no, they don't have that option of having their feelings hurt.
That's right.
The constant issue for us is, you want to do X, how is this going to work?
I just have a couple of comments, and I'd like to share some research that I've done. First of all, I'd like to thank Michelle Mongal, MLA from Nelson Creston, to come out to our meeting tonight. Thank you very much. And I'd like to make a comment about you guys up front there. I think you guys have done, under the circumstances, a great job. I think the high point in the work that you've done is getting John Ross here. I think that is going to lay the groundwork to be able to deal with the situations here in Kaslo, so thank you. So I've been doing my own little research in the last little bit, and a year ago on September the 13th, 2012, in this very gymnasium, we had the meeting with IHA, and they said numerous times that night that they were going to beef up our health care, our 9 to 5. And I've heard recently too that they have said that as well, that they still have a plan for us to beef up our primary health. And like I said, I've done a little research, and here's the, I don't know if you can see this, but this is the Canadian Medical Association Journal. This is the journal where a lot of health authorities across Canada, all across Canada, where they advertise for positions vacant for physicians. In this one article, this one journal, dated April 16, 2013, there's 35 ads for physicians. 16 of those ads are with Interior Health. Of those, there are positions vacant for Kamloops, Kelowna, Clearwater, and a number of other places, but the one thing that's missing is Kaslo. This was dated, again, April the 16th, 2013. Now, you might think this was just a mistake in one journal. Well, I don't have all of the journals. I don't have all the journals between September the 18th up until June 11th, which they started to put ads for Kaslo in late June or July. But here's the list of them. So there's the September 18th, 2012, there's 13 ads placed by IA. or Interior Health, 0 for Kaslo. November 20th, 2012, 14 ads by IHA, 0 for Kaslo. December 11th, 2012, 14 positions vacant for physicians placed by IHA, 0 for Kaslo. Bit of a gap, March 5th, 2013, 18 ads for IH, 0 Kaslo. April 12th, 16 ads placed, 0 for Kaslo. May 14th, 19 ads for IH, 0 for Kaslo. June 11th, 2013, 11 ads for IH, 0 for Kaslo. My question is, we can't fire them, can we audit them? Is that a possibility? Because what they're saying, I fully acknowledge that there may be other forms of looking for positions vacant for physicians for Kaslo. I acknowledge that, but that, and there's also the BC Medical Journal with similar stats to the CMAJ. We can't fire them, but it looks like, to me, that I don't see a lot of evidence for advertising for Kaslo. Can we audit them?
Thanks, Glenn. We knew that Glenn and his group had done a lot of work on this, various questions, and we thank them for that. And that's great, just great research. And I think you deserve a round of applause for that. I'm not really sure why Andy handed me the mic to answer the audit question, because I don't know the answer. But there is, and maybe, I've heard Greg mention this before, there is, I understand that there's a sort of a general audit process for the province or for each of the provincial government components. And I can't see why not. And I take it the goal of any audit would be to find out where the gaps are in, or where the money's going. So, and I think there's a general feeling that the powers that be want to cut services at the grassroots where we need them and where our safety's involved, but it's overmanaged. I think that's a big concern. It's a perception. And we'd all like to see that. So I don't know the answer to your question, Glenn, but we will find out.
Robin Cherbo, City of Nelson. I'm a counselor. I just thought I'd give you some information what we went through when I was co-chair of SOS. So first of all, we tried to take them to court over timely access to health care, and there were a number of other things listed. It took 3 years to get a court date, which cost us, I think, up to $50,000. And when we finally did get a court date, the lawyer said we needed another $50,000 to proceed. So I don't want you guys going down that road. That didn't work. And then just a comment, my comment is that ever since IHA took over, when I worked for highways for 35 years, every 5 years we'd have a reorg, and then we'd go through the process of getting everything working again, and then 5 years down the road we'd reorg again. Well, what's happened with IHA from what I can see is they continually reorg. I don't think there's a day that goes by that they're not changing something. And in our ER in Nelson, from what I was told, is when we had the old ER, before we moved into a new one, an RN retired. A 12-hour RN retired, and they replaced that position with an 8-hour LPN. And that was before we moved into the new, larger ER. And we just had a situation with, and I can tell this because it's public knowledge, the head of Kameko ended up going into our ER on the weekend. And to make a long story short, they told his wife that it would be a long time to get an ambulance and she should drive him to Trail, which she did. So she drove him to Trail. In the meantime, he was almost passing out in the car. And so we talked to the Minister of Health at the UBCM about ambulance care, and we were basically got no answers, similar to what you folks have gone through. And just the comment about getting an audit or getting money, we asked for an accountability of the finances, and they told us they would charge us $60 an hour to give us that information, any information. And then when we got freedom of information, things. Not only were they not blanked out, the page was blank with a header and a footer, and the pages they sent to us were blank. So anyway, but you know, we continue. We still have our SOS group in Nelson, and I'm treasurer, and we still have the health task force, of which I'm chair. And one thing we did get, we tried to get, Dr. Maiden was having to charge $300 an hour for Avastin therapy, and I wrote a letter on his behalf, and result of that, they didn't give it to him, but they sent over 2 physicians from Kelowna that do cataract surgery and Avastin therapy at our hospital. Anyway, thanks.
Well, I might speak out of terms, but I want to say thank you very much for all the nurse or retired nurses that are here, because they do always like overboard like what they're supposed to do. Have been under pressure or whatever, like some of them going through hell, thanks to interior health or interior health. I do not understand why can we get of interior health and get like maybe associate with another Vancouver Health or any other association. Because this company is overbearing with like what they have management. You cannot have like, there's 3 managers for like housekeeping, for example in Kaslo, for just housekeeping and like cooking, and that's it. There's 3 managers, which actually like, why you have 3 managers for a small, you know, like, I do not understand the way it works. But the only thing I know is they will never work. They don't know, they're too heavy in management, and they should not be where they are. They don't believe, they don't deserve the power they have over everything else. And why all the doctors are leaving? The only reason is because they've been mistreated. I know a lot of good doctors, ER nurses that were there, they left, and then for one reason, because they treat them like, I will not say the word, but shit. Have that contract. So somebody has to stop them. Somewhere, somehow. Somebody has to do something about it. That's all I have to say.
That's a hard act to follow.
Please try.
My name is Sandy McLeod. Some of you will recognize that name because it's been batted around now because of the airport. We're new residents here. We've been here just about a year, and we've been in and out with our husky dog for the last 3 years. We lived in Kaslo for close to a year and a half before coming here. I'm a born resident of BC. I was born in the Lower Mainland. My great-great-grandfather was the founding Reeve in Mission City for 4 terms. So I am one of you, and I've been in the province a long, long time, and I've been international for a long, long time. We own an aerospace aviation company that's now based here. It's based in Alberta as well. The reason I'm going to speak to you tonight is twofold. Number one is health is the number one factor, especially in British Columbia, because you're a long way from anything, especially in personal support. The second thing I'm going to talk to you about is the airport, which is developing very rapidly, being pushed by an exceptionally good crowd of people. I'm very proud of the whole works of them. Your mayor sought me out, Greg, and we've had hundreds of meetings together. I admire his initiative because it's a very important one to each and every one of you and your children in this room, and your grandchildren. I have some of those too, so I understand what that is. Your area ambulance situation is dear to my heart because I've been in the business for 36 years. I'm an ex-military person internationally for 10 years. I'm a decorated military person, so I've had exposure to a lot of incidents. We have an intended goal to open your airport this winter. We're hoping we get that support. And I'm going to have a question for you at the end of this, which I want you to raise your arm to. or don't raise it, one or the other. Number one, emergency health, there is no replacement for it. Once you're in trouble, you're in trouble. So the only way you can get help is to get there. There are 5 airplanes available. I have in my hand here a diagram of where they are. And your local airplanes, fixed wing, and the fastest ones are King Airs right now that will land on this runway as we speak. They're 300 miles an hour. You could be in Vancouver in approximately 1 hour and 15 minutes. That's right to the airport, on the ramp, and in a vehicle on your way to the hospital. You could be in the foothills in Calgary in approximately 30 to 45 minutes, straight across. You can have a helicopter service out of various centers here, but the closest one is down in Nelson, which is very good, by the way. All the services that are airborne, as far as I know, Kaslo runs these fixed-wing airplanes in the province. They have them in 4 locations, Kelowna being the closest one. And they run these 6 or 5 King Airs, and they have a Citation jet. Having said that, it is critically important for you to understand that it takes approximately 3 hours on average to get an ambulance here to the hospital and get to Nelson. The reason I know that, because I was in it 3 weeks ago, personally. So, to back that up, the service was exceptional. I have nothing negative to say. The only problem was they couldn't do it fast enough. If I'd been an hour later, I would have had a whole lot more damage. Going on to the system of the airborne situation with the runway up here in Kaslo, it's in exceptional good shape. It's one of the best in the country. In fact, it's a tremendous asset. I'm the guy that spent 7 months, 700 hours evaluating your runway. I did it internationally with the US, all across Canada, 50 specific airports. You have one of the best. It's a tremendous asset. I'm going to close this off by now by asking one specific and very important question. I want you all to think about it as I speak. This is a life-preserving situation you have here. So I want all of the ones who are encouraged that would like to have that airport open all winter, would you please raise your hand? Thank you so much. I will volunteer myself now. My wife's going to hate this. I will volunteer now to try to help coordinate Kaslo's air service transport system in connection and complete harmony with your emergency response system on the ground. Monica and the fire chief actually ran the ambulance I was in, and they did an outstanding job. I want to thank you for your time. And especially want to thank you for coming out, and I'd like to see you get a little more passionate about this.
So I understand you guys are looking for creative ideas, and I have one that might be a little too rebellious and possibly politically incorrect, but you know, when it's about life and death, you gotta get a little serious. So both Greg and I sit on the West Kootenay Boundary Regional Hospital Board, I as Andy's alternate. And this board, quite a while ago, changed from having much to do with operations and only focuses on capital infrastructure. With that, every month we go to these board meetings and we vote yea or nay on costs and whether or not we're going to contribute our part, which can be up to 40%. Of whatever the cost of whatever the capital thing is they're asking about. My possible negotiating tool would be that until they're willing to pay attention to this Ross report and we feel as though we are safe in this community, Greg and I vote no to any capital requests.
I share Amy's concern about the directive of the hospital board. It involves the Central Kootenay and the West Kootenay. The legislation is very clear about boards. It's a hotly discussed topic concerning if you're going to spend capital, Do you have the labor to go with the capital? And issues around public input into what these facilities might look like in the future. I will talk to Amy about this. I'm trying to think, when was the last time this was done, seeing as how the budget's been passed for this year. But it's certainly a consideration to remind these people that our money should be spent where the people want it spent, not necessarily where IHA want it spent.
Well, I remember a year when I sat on this, when we delayed the budget until IHA agreed to issue a license for us to put a water system in. So I see no reason why you can't talk to your colleagues about not passing the budget next year until they deal with this situation.
Good.
And I do want to note that we've just had our emergency room renovated. So I think when we go to the hospital board on the 26th, Greg, we should discuss previously any kind of concerns over what's now going to happen to that lovely renovated emergency room. And how well is that money really being used?
Our money.
I hate to think that the people in Alberta are smarter than the people in BC. They fired their boards and put an administrator in charge of the whole thing. That's my understanding. They fired their healthcare boards in Alberta. Closer to your mouth.
Can't hear you.
Alberta fired its health boards. This is to Andy. I may be worrying unnecessarily, but we recently had a federal riding boundary change. Kaslo and Nelson are now part of Penticton and Ottawa.
No.
Sorry. But it's my understanding that Penticton, IHA is in Kelowna, right? There, for us. But Penticton wants $300 million to expand its hospital. Might be fairly. But my concern is, with the riding boundary change, and I know there are two entities here, but with the riding boundary change, and we being with Penticton, Cranbrook, are we going to have to travel? Are they talking about nothing to do with Well, I'm concerned about funding for healthcare, and I'm not so sure. This is my feeling. It's a feeling of uncertainty that there's a bigger picture here that I'm not totally clued in on. It seems to me that I don't know how many other areas in BC are going through these convulsions, but a lot. But there's something terribly wrong here. And I'm not sure that somewhere up the food chain there isn't a political agenda here. I may be wrong, but I'm not feeling comfortable about it.
I don't think the federal boundary changes have anything to do with it. But there were 52 ER closures, permanent and temporary, last year in rural BC. I sit on the UBCM board with the mayor of Stewart, who is the small communities rep. When Northern Health made certain changes to their system, all of the paramedics quit in Stewart. And I worry about the kind of changes that are being proposed here, putting our paramedics in a very difficult situation. The issue really is pre-hospital care. Our acute services ended in 2002 when IH came in. But the issue becomes, what does a citizen do when they need medical help from 5 o'clock on a Friday evening until 9 o'clock on a Monday morning, or from 5 at night until 9 in the morning? And I know, because I've done some research, I've talked to paramedics, and there are times when someone simply cannot be put in the back of an ambulance and shipped off to Nelson. They need to be stabilized here. And I want you to think about a situation we could end up in
No doctor here. The ambulance goes to Nelson and gets diverted. Someone has a medical emergency. We have no paramedics, no doctor, we just have the first responders. That's the situation. I keep pressing IHA. How's this model going to work?
I'm not feeling, just because I don't feel comfortable about this whole situation. It's very personal for us in our family. Not happy.
Let me just, now that we're way out there, there is a growing number of voices, the Mayor's Caucus comes to mind, where we think there should be two health authorities, an urban health authority and a rural health authority. The reason for that is that these two authorities need to collaborate, because we all recognize if you've got a heart problem, you're on your way to Kelowna. But I'm looking at this duplication of services. I'm looking at the top-heavy nature of the various health authorities. The issue that if you're a doctor, you'd probably rather work for Northern Health because they're a nicer employer than IHA. I mean, if there's a competitive situation there. So I'll plant that seed there. I'm 73 this coming April, so I could be up the hill by the time we get it together to provide health care that is collaborative and based on rural needs complemented by urban needs.
I'm going to talk about some issues that have already been brought up. In Dr. Ross's report, he refers to 7 guiding principles of successful work relationships. We've kind of touched on the management issues and the problems with management, but he focused right in on talking about those 7 guiding principles. The 2 that leapt off the page for me are trust and respect. So my question is not really just for this group, but for the community and for IHA. How do we move forward with IHA, given that these 2 principles are viewed by most of us as being completely missing? There's no trust and no respect at the moment. How do we move forward with IHA, given that these, how do we trust IHA to engage in sincere negotiations now, given their track record over the last 12 months? Some more questions. So here we are with IH telling us that the best plan is to beef up, that's their language, primary care. They say they're already doing so. Does anybody see any evidence of real improvements more than 12 months after this was promised? Does anyone have the sense that interdepartment relations are any better at our facility or between our professionals and IH management? Do we have improved outcomes? If not yet, when will that happen?
Never.
They say we're beefing up primary care. We ask, where's the beef? It's my opinion that IHA's summary of the Ross report is a disgraceful glossing over and largely a dismissal of Dr. Ross's findings. That is an insult to this working group and to the citizens they represent. IHA is underestimating this community's tenacity. I'm angry, we're angry, and we won't back down until we get what we need. We're just getting warmed up.
Thank you, Andy. I just want to sort of, I guess, put out one cautionary note here. I know that we all talk about interior health as an entity. And I think the one thing we need to keep in mind, or hopefully, I guess you can call me a Pollyanna, but I try to keep in mind, is that interior health is made up of a lot of individuals. We've come across some in our negotiations who I believe truly have our best interests at heart. And they work within a difficult to move organization. and I think they're often and sometimes overridden. So I just think we need to be careful that we don't always paint everyone who works for IH with the same paintbrush, even though we may feel as a total organization that we're extremely frustrated. And I echo that. And it's just a cautionary note, because we have, as a group, run into a few people in interior health who we've established good relationships with, and we hope to continue to have a positive relationship with as we move forward.
Thanks for that. So just as a follow-up then, and a suggestion perhaps, as the working group moves forward, could you take the position that those who are not cooperative are not welcome at the table?
Okay, we met for 3 hours last night, and one of the critical things was we said, what can we ask the community to do? One of the things that all of you could take the time to do is to sit down and write a letter to the Minister of Health and Dr. Halpay. We have reported back to you about what the situation is. We need people in large numbers to write and say, we want something different. We have tried to do this with integrity. And Maggie's right, we don't want to personally blame anybody. We want a service that works. We want to break the mold of what healthcare has become in this province. We can do better as a people and a province on healthcare. Someone has to stand up and say, we've had enough. We did. We want our healthcare system back, and we want it run right. And there are good people in the healthcare system who want to do that. We've been talking to some of them, but they're not in charge either.
That's the problem.
Why not we can direct send emails with the questions that want to report, because every piece that they keep denying or not answering, everybody indicate those mailboxes with questions about those particular items.
When we say write a letter, send it snail mail. Paper, not email or anything, or it will make a bigger impact.
We're asking that you send it, we're asking, in fact, we have a list, Tom, what happened to that?
The list was circulated.
Yes,
I think
yes.
there's some at the back still too.
Those are the addresses for people and media sources that we would like you to concentrate, because the idea is that if we concentrate those letters on a few individuals, it has a much larger impact than everybody just kind of scattering and writing letters to whoever they feel like writing a letter to. So we've given you a list of those people that if you have personal stories, if you have incidents that have happened, I think those can be extremely powerful, and it's important that you share those. It's important that that type of information comes to light. And so we're giving you in this list an avenue so that when you run into problems or you have experiences, that you have someplace that you can share them. Is that?
I used to work for Interior Health, and I was appalled at the disrespect for my clients. When I went on, I was asked at the last community meeting if I trusted, and I said, yes, I'm going to trust. Now, I trust a little less, but I'm not giving up. And I hope you guys jump in and help out. Please.
We can't fire them. We've heard that. And there's been some really good ideas thrown out tonight. One of the ones that I have learned over the years that I've worked in a corporate setting is that the corporations don't really listen until the news media gets involved. And the other thing that they listen to is when they don't receive any money.
Mm-hmm.
And civil disobedience is not particularly wrong. And it can be very effective if everybody takes the turn that has the opportunity not to pay their medical premium for the next month or 2 or 3, and gets the news on to CBC and some of the other news stations, and then gets coverage from those news reporters as to what is happening in the community, what is happening in all of the communities that have had their emergency services cut back or eliminated. And I don't know if it's legal or not, but I don't think they're going to arrest everybody in Kaslo for not paying their premium for 1 or 2 months. Thank you.
Can you guys hear me? So, as a healthcare worker, I'm well aware of all the cutbacks that the entire healthcare system is faced with, and I think I can speak for every healthcare profession when I say we have been stepping up to the plate and doing what we can. The frustrating part from my point of view is while we're doing this, we're watching this bureaucratic entrenchment and entanglement grow, and grow. Nobody's looking at them, pointing fingers at them. And I'd just like to see some light get shed on what they were spending, and including on our hospital here. Because I'm sure it's just a disgusting mess.
Who does IHA report to?
Minister of Health.
And is it the Minister of Health that, like you said, people get overridden? That maybe their credit cost get overridden? So who does that? The Minister of Health?
Yes.
By himself. By himself.
What with his staff.
So that, like, would we be better off to try and convince the Minister of Health that we need our hospital instead of IHA? Because aren't they there trying to protect the budget of the government?
The Minister of Health is one of the people to write to. His address is on that piece of paper.
And I understand that. It just, the frustrating part is it seems like you can try and have the best ideas in the world, but if IHA just determines that you're not doing it, then you're stopped right there at IHA. But if they have a boss that overrides their decisions, then shouldn't we try to get closer to the boss in somewhere or other rather than just write a letter? But yeah, because you were talking about doing that, and if that's our best avenue to do it, we should all do that then. Because we heard that at the last meeting, write a letter to your MLA. Will that get us anywhere?
Well, we've specifically said you should target writing to the Minister of Health and to Dr. Halpin. We've given you 2 people that we would like you to focus your attention on. Dr. Halpenny's office is in Kelowna, that's correct. The minister is in Victoria.
Well, why don't we write a petition? Everybody in Kaslo will write it to the same person instead of like.
I'm not trying to jump around you guys.
No.
You're doing everything you can.
We don't think a petition's the way to go. We think individual letters. And if you want to go and visit Dr. Halpenny, that's your choice. If you want to go and visit the Minister of Health in Victoria, that's your choice. We're your negotiating committee. We're here tonight asking for some support to back us up.
You got it.
The ideas that you have to encourage the people to come to the negotiation table and negotiate in good faith with us. How you get them there, I don't mind. We need them at the table, and we need them to negotiate with us in good faith. Because for 12 months, we've tried to negotiate in good faith. We haven't said no to solutions that we think might work. We've said no to solutions that we don't think protect you.
You've done your negotiating with the government, and it doesn't seem like they're really listening. I have two ideas that are sort of out of the box. One of them is to get the Minister of Health and the head of the IHA up here in the middle of winter and give them 3 days and 2 nights and make them drive to Nelson in a snowstorm so they can understand what we're dealing with. And also, I would think that if we could have some kind of better road without avalanches all the time. So maybe they need to start improving our roads so that if we do have to drive there, or in an ambulance, because I've worked on that road and I know it's shut down 3-4 days at a time, and they haven't been upgrading that slide at Coffee Creek, right above Coffee Creek on this Kaslo side, and it's going to go again. They obviously have a different plan for us. Maybe we have gas and oil here that they want to develop, or something, you know. I mean, they've done a real good job of trying to divide us up as far as the electoral districts are. They've divided us up so we're just like a crosshatch of people. And we're the smallest group probably in this province. And why have they done that? Because we are effective when we decide we're going to do something. I would really like to see them drive to Nelson in a snowstorm. Really.
Well, just want to remind you that there are 2,500 permanent residents here. That's a lot of people.
Hi, Susan Hewitt. I just wanted to get back to the physician recruitment. I can't take all the credit for looking this up, but read an online article on Monday, I believe it was, and I won't quote the publication because I can't remember which one it is and I don't want to get it wrong, but the medical clinic in the mall had an article on there about them having had 2 physicians and now they're up to 7. They successfully recruited 5 physicians in their clinic, and one of the things that was stated was the physicians liked the fact that they didn't have to do the billings, that there was somebody else who managed the office and looked after the billings. So have you spoken to them or even thought about a private clinic model? And I know there's also one in Preston that was started by a couple of people, which I can give you the names of, and they do the same thing. They've invested their own money and they've hired the staff. They look after everything. Because we need physicians. You know, all this other stuff is, you know, we do need to write, we need to look after all these other things. But once your group gets the contract language sorted out so we can get physicians, so that they've got clear language to negotiate on, we need to start getting them here.
One of the things, yes, we did see that article, yes, we are aware of Preston. One of the things that Interior Health has said to us over and over again is that they could recruit physicians tomorrow, all the physicians we want, if they don't have to do 24/7 ER. They repeated that over and over to us. The Kootenay Lake Medical Clinic, which is the one you're talking about, which is in the mall, they do not have any requirements for any on-call. Those physicians simply come in and they do their job, their few hours or whatever that they have to do. It's a great situation. It is not our situation. Creston, it's a fee-for-service model. They have a lot more physicians, bigger community. And that's one of our major struggles, and I think everybody recognizes out there. We have a small community. We would have a limited number of fee-for-service physicians that could actually make a living here. It might be difficult to actually have a fee-for-service physician try to come here and make a living. One of the reasons that they moved to the model that we have here, and I'm not a proponent of either one, but it's interesting in talking to some other places that are struggling, is that they want our model. They're saying that they're struggling because they have a fee-for-service model And they want a Kaslo type model because that guarantees the physicians an income, just, you know, and an instant income versus a fee-for-service physician trying to build up a practice. So yes, we've looked at all those, but our situation is just a bit different here.
I do know that in the Preston clinic, that their doctors do have to put in time after hours in the hospital.
Let me, because actually I brought that up today in a conversation I had with Dr. Burton. So it's interesting that you mentioned that. And I brought Preston up, and here was the response. He said that when you have a large number of physicians, I think they have 14. When you have a large number of physicians, it's much easier to get physicians to come in and agree to working after hours, because their feeling is that with so many other physicians to back them up, there will never be an expectation that they are going to have to all of a sudden start covering other hours. This, and again, I'm just sharing information. The feeling was that because we did not have, we were such a small complement of physicians, that physicians are nervous about being responsible for 27 ER, because there are so few of them that they feel that the burden, should there be even one less physician, becomes really difficult to handle. And again, there's always a comeback from IH.
Well, thank you all for your time that you've put in, and thank you for looking into that.
I almost got ambulance. I'm waiting now. Trail. I feel like getting an ambulance for my roommate. And I almost died coming from Preston. And my mom, she brought me out by the hospital. Took me out of the hospital in Preston, and my eyes were starting to go backwards. And so I don't want to feel like getting an ambulance for my roommate from Preston, or getting a roommate go Trail or Nelson, or when we have a Frederick hospital here. And I can't figure out how come we can't get a good hospital going here, and when we have a good hospital going here, and what's wrong with the hospital?
You're right, we all feel the same way.
A major issue for us, of course, in our community is that we're struggling through a shift in our economy. We're in the process of moving into a new economy, and that economy is based on amenities that we have. Magnificent environment, we have a natural environment, our small rural culture. Doing that means a difficulty. It won't happen. It just won't happen. We won't make the transition. This community will die unless we have decent health care. We will die. It's essential for this community to continue. Thank you.
I don't like these things. Okay. First off, I have to commend you guys for working or trying to work with the IHA. I'm a pacifist, but I think I would have gone a little bit ballistic given the circumstances you were in. Okay, saying that, I'm also an ex-social worker, which means I need to do community action things. A lot of people will say they'll write a letter, but they won't. Much easier to fill out the form letter with your name and address. I mean, I could write such a letter, but I might not have your personal stories to it. But still, I could write a letter. We could put it in a central place, and if you don't feel like writing a letter, you could put your name and your address on it and sign it and mail it off. I would even be willing to provide the stamps, okay? I personally, when I want to get attention from somebody in the government, I send things either registered or certified mail. Because then they have to sign for it. Even better if they have to go down to the post office to pick it up and sign for it. They get tired of that kind of thing. So really, folks, if you don't want to write letters, there's an alternative. Help your neighbors do it. I'd be willing to do it. If we had put it in a central place like the post office, or, poor Ward, he's got too much going on at his place. Something like that. One other thing is, coming from a social work background, when we couldn't reach agreements with our clients, we went through legally mandated, legally binding mediation. Is there no way that we can install a mediation on this board so that there can be some conclusions reached? Because the way it is right now, we are at a stalemate. And mediation would mean a win-win situation for everybody. Not win, not us win everything and them lose everything. But maybe we could introduce the idea of mediation rather than confrontation.
Well, I think first of all, you've got to try and get people to the table to seriously negotiate. I really like your idea of doing a write-in. The seniors meet down at the seniors hall on a Friday. Go down there, help people write letters. Yeah, get people to help you. Have a write-in. Be creative in the way you do things around this issue. Great ideas. Organize it. Put a sign up at the post office saying, we're going to be writing some letters today at this time at this location.
Yeah.
In your neighborhood, go door to door and say, come to my house tonight. We're writing letters to the Minister of Health tonight. Start being creative.
Maybe using the Kaslo community web also to get organized would be a good one.
I was amazed at the number of people who aren't on the Kaslo community web.
They found the dog I lost in 15 minutes.
And is there a way to get mediation involved? Is there a way to do an end run around IHA when we're not willing to negotiate?
Tom?
With mediation, yeah, I'm a mediator, a family law mediator, and I know that, that you have to have, that you have to have both people wanting to mediate. They both have to want a solution. And, I don't think, I can't speak for IHA, but it doesn't seem to me that there's any advantage in them to come to a mediation table. What we're doing is trying to negotiate, and we're negotiating in good faith, and the negotiation and the mediation are really very similar, except that with the mediation you have a third party who's trying to assist. It's an idea, but I don't see that happening in this case. I think our negotiation is hopefully going to work. I think that's the best we can do right now anyway. With the letter writing, I have to disagree with you a little bit on the letter writing. First of all, petitions, let's start there. Don't even think about a petition, in my opinion. In my opinion, they're actually counterproductive, because people put their name on a petition and they think they've done their thing and they go home. And that does nothing. The person at the other end of the line gets the petition and throws it in the waste paper basket. The form letter idea that you have, well, that's the next best, but with respect, I just don't see that form letters have a lot of impact. I think everyone sitting here, if they're not willing to write a letter, then they're not willing to do their part for themselves and for their community. They can be half an hour and do it. And actually go home and do it either tonight or tomorrow. Because if you don't do it by tomorrow, you won't do it.
Hi, I'm Jessie. I'm one of the nurses at the hospital. Healthcare is really important to nurses, that's why we're nurses, that's why we chose this profession. The Kaslo nurses, they just want to do what we care about, we care about your families. And we're really upset and sad and sorry about how all this is going down. Are feeling a little disrespected because, you know, once again, we're not really getting the message before everyone else. So as a working nurse, like most nurses in this province, I'm a member of the BC Nurses Union. And part of the BC Nurses Union strategic objective submission statement is to promote and protect a publicly funded healthcare system. And for myself personally, that's where my involvement mainly comes from because I feel so passionately about it. So I just want to say, like, when the working together part, that BCNU, the nurses in the union, are willing to work with others in this community to support a 24/7 healthcare system. And
Thank you very much.
we really want to work with
I just walked in here from being in Nelson this afternoon. I first want to put on the record, I am not on the payroll of the local MLA, who is a grad of University of Alberta and of Royal Roads out on Vancouver Island. I have no idea what transpired. I see there's one representative of the legal community at the table. I'm going to suggest, perhaps, that people do on the big picture, because if the Minister of Health in this province is suggesting Doc Hollywood, and I don't look at those kind of videos, I live it. I'm going to suggest, perhaps, for people who have the ability, the time, the effort, to research the Canadian Medicare Act. In 2000, out on the west coast of Vancouver Island, people formed the Victoria Health Coalition. I was part of that. Did media relations with a few helpers across the country. Because people could see what was about to perhaps happen in beautiful BC after what started in Alberta, namely Statute Law Bill 11, under an administration not of Alison Redford's. I'm going to say this because I feel so passionate. I'm an educator. I have no medical credentials behind me. At that time, after the big event was over, I was exhausted from what it took. Shirley Douglas was there. We brought her in from Ontario. I called to the then Minister of Health's office in Ottawa. His Western Canada assistant I had known from other settings. The minister was Alan Rock. And the person said to me, and I'm paraphrasing, I have a fairly decent memory. They said, I'd like you people to do around the province what you just did in Victoria that weekend, because they were concerned what was going to happen to healthcare in British Columbia when government changed in 2001. The person started telling me about the ins and outs of what had gone on behind the scenes in Alberta. I kept saying to them, look, I am not in party politics. And he kept telling me, I didn't make notes. What I'm saying is this is a big picture. It is not unique to this province. The demographic in Canada is changing, we all know that. And for people who feel that they want to address the matter of local health care services under IH banner out of Kelowna, which is really a small part, I suggest looking at the big, big picture. I'm going to leave it at that.
Margaret Rowley, I'm one of the RNs at the hospital, although I'm a perfect problem, because I've been off work for over a year with the diagnosis. But I have a couple of questions. Do you have any idea why I don't want to work on this cross recommendations? Why I'm not negotiating anything? Do you have any idea why they refuse to?
Well, I mean, they're not refusing to work. What they're saying, they're telling us now, as of today, is that they will be working with us collaboratively on those Ross recommendations. What we've said is that over the past year, we've, despite, you know, all of our efforts to work collaboratively, we haven't made much progress in that respect. But they are telling us as of today that they are willing to work with us collaboratively to implement some of the Ross recommendations.
But that
We just have to wait. I don't know.
But that includes closing the emerge for part of the time. Mr. Mayor, I have a question for you. If I heard you correctly, you said that Dr. Halpenny said there will be no emergency services in Kaslo? Or was he referring to part?
The only part of the conversation I remember with him was that we don't agree. Andy stayed after I had to leave for another situation, and he could probably clarify exactly what Dr. Halpenny said.
So, what I heard Dr. Halpenny say was that the ER was being closed and we're going to have 24/7 primary care. Trying to get him to explain what that meant was like trying to understand the shape of Jell-O.
Well, as one of the nurses there for a number of years, you guys have to do something. Write those letters, do something, because something's going to happen to one of you, and it's not going to be a good picture. Because it's already been brought up, if you got the one and only ambulance in Nelson, and the emerge is closed, and the doctor's not available, what are you going to do?
Die.
And I've already been on duty when the ambulance has been in Nelson, and the ambulance was called out, and there was a collapse downtown. So the emerge was open, the doctor was available, so the first responders took care of the situation, brought the person to the hospital. But if you don't have anybody but first responders, and you have a critical event, something's going to happen to one of you. And you need to get your hands working and write those letters, do whatever you can to get them to the table to negotiate this problem. And I don't know why they can't ask the doctors what they want to come here. Because I had a head nurse at Royal Columbian Emergency ask me a number of years ago before I moved to this community, well actually I don't live here, but live close, and said, what do you want, Margaret? And I said, well, I only want to work half-time. And she said, okay. And she says, well, I need someone in the emerge holding you. I said, I don't want to work there. She says, I'll pull you as often as I can. So I came to work there. We negotiated, and I worked there. So I don't understand why they can't talk to these doctors that have shown some interest and just say, what do you want to come to Kaslo? If that means they want to work 3 days a week, 1 night on call, take them. The next guy will do 3 days, a night on call. Eventually, you'll get all the doctors you need. And if you treat the staff that are working with dignity and respect, you'll get nurses, and they'll be happy to work there. Thank you.
So, we thank you. We will continue to negotiate, and write those letters, and think of creative ways to get Dr. Halpenny, the Minister of Health's attention. Thank you very much.
I would like to mention that a meeting today was at the CBC. It was, I had it this morning, and the meeting in Kaslo, I was very surprised, and it was on CBC.
Thank you very much. Yeah, could you, some of you help us put the chairs away? And these reports, I understand, will be in the files.